effects first. Then we'll talk about hormones because we're going to focus on the hormones. So FSH, its function here, it's going to stimulate in the ovary the follicle to mature, follicle stimulating hormone. So we're going to take a couple of these follicles, one becomes the dominant follicle, and we call that the Graafian follicle. So when it fully matures, great Graafian follicle. And inside we have a secondary oocyte. It's surrounded by cells called granulosa cells on the inside and theca cells on the outside. We'll come back to that because the hormones are going to be made in the granulosa and the theca cells. LH, it's going to stimulate ovulation, so release of the Graafian follicle mid-cycle, which is roughly day 14, but again, that varies, obviously. So they're the kind of reproductive effects they're going to directly have, okay, on the ovaries. Now, they're also going to stimulate the production, let's scoot this over, of hormones, right? So here we've got a theca cell. So right here we have theca cells on the outside, granulosa cells on the inside, and this is where the sex hormones are made in the ovary. The three big hormones we want to focus on are progesterone, testosterone, and estradiol. So remember, these are steroid hormones derived from cholesterol, and guess what? They all end in ONE or IOL. So ON or IOL, progesterone, testosterone, right? Estradiol. And we'll talk about some of the precursors. So LH and FSH are going to stimulate this process. So pregnenolone is a parent hormone. And again, we can actually buy pregnenolone as a supplement. So, and pregnenolone is going to convert into progesterone. So we got pregnenolone, this parent hormone, converting to progesterone. Now, what does progesterone do? So it's very low in the first half of the uterine cycle called the proliferative phase, but then it spikes up and is relatively high in the back half of the uterine cycle called the secretory phase. It's going to maintain the endometrium. It's going to cause the influx of these spiral arteries, and it's going to develop and mature these uterine glands, right? It's getting ready. It's like, hey, this is time for implantation, because if there was fertilization of this secondary oocyte after ovulation, well, after a few days, it's going to move down, well, ideally, into the body of the uterus and implant in the uterine wall, so into the endometrium. So we're getting it ready. Now, if there is implantation, we get a signal from human chorionic gonadotropin, HCG. What's that test? We test that for pregnancy in the urine, then we confirm it with blood, and we make sure it's going up, right? So that's going to keep progesterone high, and progesterone is going to maintain the uterine lining. If we don't get that signal from, to the corpus luteum, progesterone falls, and guess what we have? We have menses, and we start the next cycle. So that's progesterone's effects. It's then converted to androstenedione. So this is a precursor hormone to testosterone. Yes, testosterone is made in the ovaries, right? Everyone doesn't really focus on it. They focus on estradiol and progesterone, but guess what? Testosterone is made in the ovaries. So this is going to convert into testosterone. So it's going to move into the granulosa cell and convert into testosterone. So what is testosterone going to do for females? Well, some of the secondary sex characteristics like body hair growth, that's not really modulated by estradiol. It's going to be from testosterone. Testosterone also increases muscle mass, bone density. It has a lot of important effects. And these sex hormones, they go into the brain and bind to receptors and have whatever effects, neuro effects in the brain. Testosterone could be neuroprotective to some degree, but it's going to help with sex drive, right? Libido, energy levels, all those things that women talk about when those hormones fall and they might get them replaced, and how they feel. The mental effects. Now, testosterone then going to convert through an enzyme called the aromatase enzyme, which we talked about in the male. Aromatase converts testosterone to estrogen. You might have heard of aromatase inhibitors that you might use in estrogen-sensitive breast cancer to block estrogen or lower estradiol levels, because that's going to stimulate the tumor. Now, what are estradiol's effects? It's a ton, right? Secondary sex characteristics, breast development. It's going to stimulate, sexual function and development of the vagina. And it's going to have mental effects as well. It's going to bind to the brain, have all kinds of important effects, in the brain. And then, other effects than the reproductive and sexual effects, well, it's osteoprotective. So it's going to increase bone density, maintain bone density. It's going to be cardioprotective. So do we have a lot of women having cardiac events and myocardial infarctions pre-menopause period? Well, it happens, but not nearly as many as men. And then guess what? Post-menopausal, it goes way up. So what's the number one killer of men and women in the United States? It is atherosclerotic cardiovascular disease. So estradiol maintains a lower LDL, the bad cholesterol carrier, and a higher HDL, the good lipoprotein, right? So that's good. Now, those are the effects of estradiol. One more too, it can be neuroprotective, right? There's not as much evidence behind this, but it might protect against things like dementia, like especially the number one common dementia, Alzheimer's disease. So that's something we have to probably study more and take into consideration. So estradiol's reproductive effects, well, it's going to have two little peaks, one in the proliferative phase and one in the secretory phase, but it's also going to build up the uterine lining, the endometrium, mostly in that proliferative phase, where progesterone is going to have more effects in the secretory phase, in the back half of the uterine cycle. So those are the sex hormones, right? And then we talk about these. What's the biggest issue? Well, postmenopausal women, which I already mentioned, right? When these sex hormones drop, right, in the perimenopausal period, what happens? Progesterone drops, testosterone drops, estradiol drops, and they drop at different times. And this is the consideration for hormone replacement therapy. We talked about hormone replacement in males where you just give testosterone, but the nice thing is testosterone will just convert to estradiol through aromatase enzyme, and it'll convert to dihydrotestosterone, DHT, through the enzyme 5-alpha reductase. So they generally just need testosterone. But in females, we're going to have to use any combination of these hormones. And then you need to see a specialist who specializes in female hormone replacement because it's more complex, right? So I'm not a specialist in that at all. So you need to see a specialist, right? And obviously none of this is medical advice. This is just the science background. So you might, replace any combination of those hormones. So is that important? Well, you don't want to have a hip fracture when you're 75 and just shatter a hip and then never get back up again, right? You don't want to have a cardiac event, right, and build up a bunch of plaque in your coronary arteries. And, potentially if it's neuroprotective, maybe you'll protect against Alzheimer's and dementia, right? There's some, evidence behind that. So, it's something to consider and you have to discuss with a specialist and your physician, okay? So these are the female sex